Hello, welcome to another episode of Gastrointestinal Endoscopy's podcast series. I'm John Vargo from the Cleveland Clinic, and with me is my colleague and author of the paper under discussion, Sunguk Jang. Sung, welcome.
Thank you.
The paper is entitled Efficacy of Digital Single Operator Cholangioscopy and Factors Affecting Its Accuracy in the Evaluation of Indeterminate Strictures. As we all know, we're getting better and better at deciphering the etiology of indeterminate strictures, but there's still some gray zones. And Sung and his colleagues have utilized a large database with digital single operator cholangioscopy to really get into the meat of the situation in terms of what factors affect its accuracy. Sung, can you tell us a little bit about what the background and why you decided to do this study?
Thank you, John. So the cholangioscopy and its technology has been with us for quite some time. It is the invention of the single operator cholangioscopy, the semi-disposable one that actually was developed about 10 years ago, that in my mind really revolutionized and expound its utility. As you know, that technology was relying upon the fiber optic based imaging. And even so, it was quite helpful for us to determine the nature of the biliary strictures. And yet, the limitations of its technologies actually has still handcuffed us for us to obtain ideal samples, as well as improving the accuracy of interpretations. And as you know, the new generation of digital single operator cholangioscopy was developed roughly about 4 or 5 years ago. With a lot of fanfare claiming that its accuracy potentially could be improved. And what I wanted to see is that true? Can it be validated in two facets, if you will? One is how good are we using this technology in terms of visual interpretations? And also how good are we in terms of getting the bile duct sample with this technology? As we all know that the previous existing technologies such as the ERCPs, even with the fluorescein in situ hybridizations, the accuracy of the samples have been much to be desired. So that is the impetus behind us diving into this study.
Okay, Sung. So we're seeing things better. So what were the factors that affected the accuracy of ultimate diagnosis of a malignant indeterminate stricture, if you will, as opposed to a benign?
So throughout the many studies that came out, there were certain criterions, if you will, or the visual characteristics or clues that we were told to look at, namely examples of the vascular patterns. So, for example, if there's a nice palisadings of the vessels, those are usually of a benign type of vessel, whereas if we see very ectatic or irregular vessels that may confluent at times, that raise our suspicions for potentially this being malignant. In addition, we are also told to look at the epithelial characterizations as when we use this single operator cholangioscopy. Now, all these things are based on if you will, the clearness or the clarity of what the visual cholangioscopy provide. So that is one thing that we wanted to look at. Then secondly, as to the getting the biopsy, how good or how can we improve the right area, if you will, of getting the biopsies. The traditional ERCP with the brush cytology really relies on that negative imaging of the fluoroscopic area, and basically you brush in and out those things as many times as you can, hoping that you got the sample. Now, can we target by looking at it, and actually better looking at this, and target the area of the biopsy that may actually give us the maximal yield? And that's one of those criteria that we were looking at. Said, are there any factors that can actually potentially hamper us from getting those things? Namely, as the study has suggested and reported, that those accuracies are dependent upon the experiences of the operator, the endoscopist. In addition to it, if the lumen visualization is hampered, say secondary to significant hyperbilirubinemia, pigmentations, and debris, that can potentially negatively impact the accuracy, both visual as well as biopsy acquisitions.
So, Sung, I think one of the exciting parts of this work is actually you're really starting to define a learning curve for digital single operator cholangioscopy. Yes. Can you tell us a little bit about what that threshold was?
Yes. So to go back to that, I think we as the biliary endoscopists at the edge of this, if you will, expansion of the technology, the question we ought to ask ourselves is that as these technology gets disseminated, what is the most effective or more effective way for us to use this? Not only in a big quaternary institutions like ourselves, but perhaps in other institutions that may think about incorporation of this technology. How are we going to train those people? What is the adequacy in terms of their training, and then how do we maintain their adequacies, if you will? And our study have shown that when we actually tier the endoscopists to novice, and we arbitrarily put the numbers of 25 or less of cholangioscopic experience, and intermediate, which is 25 to 50, and actually those who are considered expert, who has done more than 50 endoscopy of a cholangioscopy, there was a significant and statistical difference in terms of accurately interpreting the visualization, as well as accurately getting the samples from the indeterminate biliary strictures. So that actually should be translating as we actually incorporate this subgenre of the ERCP, and especially in the academic center where we're going to train the next generations of the biliary endoscopists, should we make sure that when they decide to go out in the practice, that we should adequately arm them with the enough training so that when they go out there, that they'll be able to deliver as effective and as efficacious treatment or the diagnostic imagings for the patients.
Thanks, Sung. A question on that 25, and I know the manuscript it wasn't able to answer this, but if there's the technical aspects of the cholangioscopy as well as the interpretive aspects. Do you think they're both playing a role at this 25 procedure threshold?
I think the technical comes a little bit easier because you are now dealing with 4 knobs rather than 2. But the idea is the same. Maybe perhaps more subtlety and nuance of your body positions or the torquing of scopes, those will come in a little bit more handy. But I would also surmise that those people who are diving into the cholangioscopies may perhaps not be the very first time ERCP attempter, if you will. Mm-hmm. These are the people who have done ERCPs for some time and have somewhat of an innate understanding or intrinsic understandings of how the biliary endoscopy ought to be. I think the technical aspect of delivery and push of the catheters, those things are relatively easier to come compared to the interpretation, the visualizations, and that part that may require a bit more of a repetitions of seeing what's normal and perhaps what is not normal.
Okay. One question I've always had personally is the potential confounding or confusion surrounding doing a cholangioscopy in a patient that's already had a bile duct stent. You've pulled the stent and there are some stent-related changes. Does your data give us any more information on the presence of a stent? Does that make the performance of cholangioscopy worse or better, or is it the same?
Yes, sir. So in a nutshell, the initial study, and when we look at those variables, one of the variables, at least in the univariate analysis, actually have shown that the presence of the stent shortly before the time of the cholangioscopy was one of the factors that can negatively impact the interpretation. As you can imagine, the foreign body being in that narrow confined space, there is the epithelializations, the reactions and such, so that when we look at it, those erythema and hyperemias, are they secondary to the just pure benign inflammatory versus the malignant, can be confusing. Having said that, when we actually parse that a little bit more with the multivariate analysis, the presence of the existing biliary stent was not a factor that affects the accuracy of the cholangioscopy.
Sung, where do we go forward now in the art and the science of cholangioscopy? What are the unanswered questions that we need to tackle in the future?
I think you kind of hit the nail when you talked about the proficiency part of it. The one is that can we validate the number, if you will? What is the optimal numbers that the biliary endoscopists who wants to dive into this technology need to have to be adequate, to be proficient in this procedure? I think that needs to be a little better teased out. Obviously, it requires a larger data, if you will, and prospective studies will be obviously be very helpful. So that will actually determine and helpful to us as to how to actually guide our trainees down the road. I think that's one of the important aspects of it. The other thing that we would like to do is actually the methodology part of it. And to a certain degree, some of the recent studies actually have mentioned that. The examples being how many biopsy samples are enough in terms of getting the indeterminate biliary strictures. As you recall, Dr. Bang and her colleagues at the Advent Health Group recently published the idea that maybe you need more than 3 biopsies for us to have a better chance at it. Now, having said that, I don't necessarily think everybody is the same, only because if the stricture, for example, is high up, if the stricture is more fibrotic in nature, do you need more numbers or not? So I think those methodologies as to number of the biopsies are also important for us to dive into with the near future studies.
Thanks, Sung. And with that, I'll bring this podcast to a close. This is my partner, Sunguk Jang, and I'm John Vargo, and it's been a pleasure to be part of this podcast for gastrointestinal endoscopy. Have a good day.